So thank you for a wonderful panel. I think I've certainly learned something about snarky justices, about the fact that the ACA is not going to be self-implementing, which I actually kind of thought it was. And I think in Jaime and Josh's comments, we've heard of the call and the need for more health policy researchers and more health policy research. So I know you all have a lot of questions. As you're formulating those, I've taken the moderator's prerogative to plant a question. So I'm going to ask Claire Brindis to ask our first question of the day, and then we'll open it up, and we look forward to having plenty of time for conversation.
Thank you, yeah, and thank you to the members of the panel. Very illuminating. I'd like to hear a little bit more about the role of technology in all aspects of the ACA, both in terms of assuring enrollment of populations that often have not even been enrolled in programs that we've had in the past, as well as improving quality and cost containment.
Go enrollment.
I'll talk a little about enrollment because I think I just want to underscore something you said that's really important. Yes, okay. So I'll say what I understood the question to be, and please correct me if I. So the general question was, what's the role of technology to help us ensure that those who are eligible are enrolling and that we are providing high quality care in terms of technology to populations that have otherwise not been able to benefit from that. Is that essentially?
And also cost containment.
And cost containment, yes, great. So
It's a softball, Andy.
yeah, no, I pretty much have it. And
Yes, that's the answer.
so, I mean, I do want to first underscore something you said, which may not be fully appreciated by everyone here, which is that there are actually many people today in California and around the country who are actually eligible for some programs as they exist today, before the Affordable Care Act even passed. So there are clearly barriers that have made it hard for people to know that they are either eligible for health insurance and don't have it, or that there are barriers that make it difficult to either get it or maintain it and so forth. And if you, I mean, just to talk about it in simple terms for the Medicaid program, you can imagine that if the program is being administered by the state, and the state knows that if it does a really good job of finding everyone, that, by the way, it has to spend more money because it now is responsible for signing people up, there's been a little bit of a mixed incentive there in terms of the state doing this. One of the nice things about the Affordable Care Act and the expansion of the population is because the money is provided by the federal government, suddenly you would believe that the state's interests are very well aligned to, in fact, suddenly go out and find people who are eligible and make sure that they do get enrolled. And furthermore, the individual mandate should help to reinforce to individuals out there like, I think I heard the government said I need to have insurance. Good thing there's this government program that I can take full advantage of and be signed up and have that covered. Now, one of the things, just to get more directly back at your question, is that the health exchange in California has gone out and, in fact, invested something like $350 million in a state-of-the-art IT system to, in fact, create a front end that will be working to try to create a simple way for people to know about their eligibility for different programs. But there are critical questions that I think are embedded in your question. We know, for example, that probably about 40% of the individuals who will gain insurance coverage are of Latino backgrounds, and so there's likely to be some language barriers that could come up for individuals or people in communities that do not have access to the kinds of mainstream media that the general public relies on. So we're going to need to be very clever about how we, in fact, do outreach to populations to make sure that they are getting the benefit of that. And technology can certainly be a bridge to that, but we also have to be careful that because we have a computer system out there, we don't just sort of think that everything is okay. And then I'll just say one other aspect. So you're also saying, gee, how do we make technology be the solution and not the problem? And if I knew the answer to that, obviously I would give it, but I think what's embedded in your question is that so much of our innovation, which has been fantastic for improving quality of life and longevity and so forth, has also been a major cost driver in our health system, that we somehow have lost the incentive structure that seemed to work so well in the polio vaccine, right? We invent a polio vaccine, it's a tremendous technology, and by the way, we eliminate a disease and we save all this money. And we just haven't had that many technologies that are as successful as that. We seem to invent a lot of things and it adds cost on top of previous costs, whether that's in the area of imaging, whether that's in the area of prescription drug use and so forth. We clearly need to have a different set of incentives that make it in the interest to both be innovative but also to reward people disseminating those things in a way that in fact is cost effective. But I certainly welcome other people's thoughts about how we do that.
No, I don't have the thoughts on how to do that.
Another question. Are you going to speak, Josh?
No, go ahead, Murph.
Oh. So, well, I'd like to thank the presenters because they obviously had 2 sets of speeches to give today and chose the right one to give. But in the realm of Andy and Josh's comments about rolling up our sleeves and what can we do now in the UC system, is there something that we're at a crossroads that we can come together as a consortium in a way to deliver to the state, being one of the 5 of the 22 public hospitals? And secondly, is there an experience that we can learn from in Massachusetts in the way that the academic medical centers perhaps came together and resolved some of their problems?
Well, I think it's an excellent point, and not something we've necessarily done particularly well as a UC system before. But I would think the key elements where we could collectively make a major contribution would be 1, access, and 2 is cost containment. And that means proposals that involve the workforce, legislative and regulatory changes, and delivery system reform or delivery system innovation that achieve one of those 2 goals. That's my, sounds like a pie in the sky answer, but I think those are really the places where we would need to focus.
I also think we have to have courage about what the new world will look like. I mean, getting a message yesterday from the court about that this is, should take some uncertainty out about implementing this law. Right now, most hospital delivery systems, including UCSF, are primarily driven still on a fee-for-service payment model. Some of the changes become more possible as we imagine and implement different payment models that give us fixed amount of money to take care of the population and incentivize us to focus on prevention and moving patients into the community rather than focusing always on bringing them into the hospital. I mean, there's a fine balance there, and I think it takes courage and leadership to know when it's time to make that transition. UCSF has been a phenomenal institution and provides both incredibly high quality care at the the highest level of need and in terms of complex care, but a lot of that is fueled by a certain payment model in some ways, and so we need to be clever and courageous about how we in fact make that transition. And you referenced Massachusetts, and in fact I think the hospitals there have struggled with some of the same issues, but have started to move a little further out on that ledge, if you will, and to make that change. And I think those are some of the discussions I'm sure that are underway here about how do we do this in a way that preserves what we've been able to do so well, but also recognizes the future and where we're trying to go.
Okay. If I could just add, I think a real problem here is getting information out. Jaime talked about how the federal government essentially is going to be, on a sliding scale, providing supplemental money for getting health insurance. When you hear debates, most people, most sort of average Americans making $20,000, $30,000, $40,000, $50,000 think that they're going to have to go out and buy insurance at the rates that they now think of it. And there's really a terrific need for getting the information out. I was listening to Talk of the Nation yesterday, and there was a guy who was 27 years old. He was a part-time janitor making, $22,000 a year. And they asked him, and it was sort of a nice moment, they said, are you going to go out now and buy insurance? And he said, well, I'm healthy, so I'm sort of that group that is sort of supporting the older Americans, but I'm patriotic, and I think that it is my responsibility, and when I'm older, there'll be younger people that will be supporting me. But it was clear within his question that he thought he was going to be spending a lot of money to buy insurance, or he's going to have to pay a tax penalty. And so there might be, just sort of on the front lines, you all are seeing the people today, day in and day out, coming to the hospitals, coming to see the primary care at several levels, getting some simple information. This is a brochure that says, this is what the Affordable Care Act does for you. This is the way insurance works. And I just haven't seen any kind of real push to get the information out to blue-collar average Americans who don't watch Talk of the Nation, don't go to panels like this, but you all are seeing day in and day out in your clinics, and they have absolutely no idea. They think that it's going to cost them a great deal of money.
Jonathan Gruber has a comic book on that, which is very good.
And it needs to be distributed in every office in California, and we should be leading on that.
So I just want to mention that we do have 2 microphones. If you have a question, put your hand up high, and as we're passing them around, I'm going to ask Jaime, you put up a map of the states that show different rates of uptake for the exchanges, and we've been talking a little bit about California, the challenges here, but which states have been slow to move on implementing this, and which states are really going to be in the most trouble now that the act has been really completely upheld?
Well, if you go back to that slide, it will tell you, but there's been 6 states that really haven't done much of anything. And you can see there's sort of the light blue states with Idaho, North Dakota, Louisiana, South Carolina, and Ohio, and they have not started at all on the exchanges. And I think they will face the decision of, whether to just sit there and cross their fingers and hope that the federal government, that the act will be repealed, or they will face and accept the fact that the federal government will run the exchange in their state and may not be exactly what they want, but perhaps they can just take that on a political line. But I also think the 12 states that really waited and halted all of their planning, waiting on the Supreme Court decision, are going to have a really hard time. I mean, we've listened to Andy talk about the enormous effort that has gone on in California to get this up and running and how difficult it has been to do that. I mean, California certainly leads the way in the development of the exchanges. So anybody that hasn't started or has only kind of started, I think, is going to have a hard time following along.
Question up here and then we'll come down here.
There was a mention of the idea that there could be litigation against HHS regulation as a next step. I wonder if you think the proposed strategy of having the states define essential health benefits in the next couple of years is a way to mitigate that risk. And do you think that this strategy might be expanded beyond the next couple of years to keep litigation as a risk lower in terms of defining the essential health benefits package?
Yes, so I think that the attempt to give states much more flexibility in how they define the essential health benefits was definitely an attempt to restrain legislation and litigation on that realm. But I do think that to the extent that any restrictions are put on how that's defined by the states, I think that we could, you could be exposed to litigation risk or chances for states to try and fight on it, for sure.
Particularly with the Medi-Cal programs, right now they are absolutely swamped underwater, doing everything they can to prevent anybody else getting into Medi-Cal. How do you see this being affected or changed with this new regulation or laws?
I'm not sure if people caught that question. So, it's already difficult to get onto the rolls of Medi-Cal, and how might this legislation impact that? Is it going to make it better, or by encouraging lots of other folks to apply, could it actually exacerbate things and make it worse?
Before you answer, I want to actually amplify how big a problem that is, because in addition to the simply gaining roles, getting onto the rolls of Medi-Cal, the state of California is in a fairly rapid transition from fee-for-service Medi-Cal to regionally based managed Medi-Cal. So the San Francisco examples are the San Francisco Health Plan and Anthem Blue Cross, who provide a managed Medi-Cal plan, which the data suggests probably does a better job providing care, but is a much more complicated organizational structure. And so if you now add 5, 3, 4 million people to the Medi-Cal rolls, that will clearly overwhelm those programs' ability to function normally.
Yeah, one aspect of this that people have really worried about is right now eligibility for the Medi-Cal program is handled at the county level. And there's a lot of state workers who are involved in that process on behalf of the Medi-Cal program. I think one of the things that could change fairly dramatically because of the involvement of the exchange and its investment in this IT that we've referenced a little bit, that there may be, in fact, a much cleaner front end to the entry into getting health insurance that may, in fact, decrease some of the personnel needs to actually accomplish this. That isn't to say it would all go away, but it might be akin to how your experience has changed at the airport, where you used to all stand in the same line with your suitcase, whether you had one or not, to check in, and now many people can, use kiosks and other kinds of ways that can speed up the process. So there would still be some support personnel to help this, but probably by relying on technology can imagine a more efficient way of handling it. But Josh is also right that even once you're enrolled in the program, there will be additional decisions in many cases you'll have to make because California has really moved fairly aggressively into using managed care as its delivery system for the Medi-Cal program. It's historically done very well with that for low-income children and parents, but now are increasingly having the disabled populations move into managed care and is getting ready to experiment with having dual eligibles, those duly supported by the Medicare and the Medicaid program into managed care as well. And so we're going to need to learn and pay careful attention to whether these managed care plans are able to provide the level of service, the adequate networks to take care of people with much higher levels of need than have historically been in the Medicaid managed care programs.
Well, one of the things I was going to say is that there are huge incentives in the bill to get as many people enrolled in the Medicaid program on January 1 of 2014 as possible, right? Because every day that they delay, you're leaving federal money on the table. So I know that organizations that are reaching out to those communities are really trying to get as many people signed up in advance. So on January 1 of 2014, those people will go on the rolls immediately. And so I think there's a huge financial incentive for the state of California to really push through on that.
Another question here.
I don't want to talk about broccoli. I do want to talk about a different vegetable, pizza. The fact is that the ACA was predicated on the notion that we'd be able to recoup costs by providing preventative services over time. That's a canard. The bottom line is we spend $147 billion a year on chronic metabolic disease, and that number is predicted to go up to $192 billion by 2020. We're now putting 32 million sick people on the rolls, many of whom have chronic metabolic disease, and other countries that have preventative services have not shown any reduction in their rates despite having those services. So the question is, where is the money going to come from, and where will it ultimately be siphoned off over the course of the next decade as these changes get rolled out?
Well, I just want to comment on one. I'm not going to completely answer your question, but I want to acknowledge something you said, which actually came up very clearly in the debate within Congress when it was dealing with this law. So, the process of passing a law in the Congress requires that any drafted legislation go over to the Congressional Budget Office, which is seen as kind of the referee for Congress. It's a nonpartisan group of economists that do very sophisticated modeling of both the current costs of things as well as behavioral changes that may come about as a result of policies, and really tries to estimate as best they can. It's really like futuristic stuff, and sometimes they nail it and sometimes they have trouble. But the more key issue here is that several provisions were written related to prevention with this very much in mind, that, gee, if we do prevention, maybe we can save money. And in fact, almost unanimously, the Congressional Budget Office came back with the answer of, Well, we've reviewed the literature, and it's our belief that you can spend money on prevention, but the evidence base for how much that would save downstream is really quite poor. And this was, in some ways, it may reflect reality. It may also reflect the nature of that we do not have enough evidence that we've done in the areas of prevention that have really been successful to be money savers. And so while there were many people advocating for the philosophy of more prevention and wellness and so forth, and you see elements of that in the bill, when it came to the test of the referees and the economists, they agree with what you're saying. At this point, there is not a sufficient evidence base for many of the preventive concepts in there. And it actually, to me, was a call to action, and I share it back out to all of you that believe in prevention, that we need to bring the level of evidence gathering that we do in other forms of clinical trials, for medications and procedures and so forth, to the area of prevention. It's a wonderful philosophy. I think many of us believe that this is a good way to go, but there has not been the evidence base yet in place to really support this as a policy lever. So it's probably part of our solution, but figuring out which parts of it still need, I think, to be determined.
I think and I know there's some questions up here, so if you do have questions, put your hands up. Another interesting thing, when the ruling came out yesterday and I saw that Roberts has actually joined the majority, I was not as surprised. It might have been because David and Andy both told me that Roberts was going to join the majority and it was going to pass. So I wasn't as shocked as I might have been. But it did give me this feeling of, well, this says something different about the politics in our country that may actually be something quite interesting. If you look at historically, the big policy changes that have improved people's welfare in this country, they've been universal policies, Medicare, Social Security, that have sort of lifted all boats. And healthcare has never been in that group. And one of the questions is this ruling sort of an indication that maybe healthcare is moving into that sort of realm of lifting everyone's boats and really addressing population issues? Because that's what the question really is about. Is this really about health insurance in our healthcare system, or is this really about improving health? And I think that it's interesting to think about the kinds of questions Andy's raised and the ways that we need to think about these issues more broadly, not just in terms of the research we do in the sort of medical model, but in a population model. What does it mean if this is really a different way that we think about the health of our fellow Americans and sort of our own stake in each other's health?
Well, on that, I don't think we're having a very healthy debate. I think that we need more evidence-based politics. And when you hear, and it's candidates on both sides, but I tend to blame the Republicans somewhat more. I think that they simply distort the record, and they make allegations and claims, and it's hard to have that healthy debate. Now, if you study Social Security and Medicare, Medicaid in the 60s, there was a vehement debate, and there were certainly questions raised, but it wasn't at the level of polarization that we see today, and I don't think that it's at the level of distortion that we see today. And whether we can get back to that more civil discourse, I don't know, but I think that it's hard to make the argument until, part of the problem, in all honesty, with this bill, and I don't blame Andy for this, but the fact that it's being implemented in 2014, that's a bad thing. People don't see, it doesn't resonate for them as to why this is a good thing for them individually, it's a good thing for their families. The parts that have been implemented, they do recognize that. Kids that are up to 26 now have health insurance. The idea of pre-existing conditions, I think, is starting to resonate. But a lot of this was put off, and it's easy to, again, distort the record if you don't have any evidence because you don't have implementation. And so right now, when you look at the debt ceiling issue, and we're going to face this again, this is going to be a very ugly political season, and there are going to be a lot of things said. And so again, it's a call to all of us to step up and help educate, to do local media, to talk to people, to get out and talk to civics groups, because I think that people need to have sort of a civilized voice coming through the din in these contexts.
I'd like to add, I don't often play the cynic, but I think in some respects, I would like to believe, Dan, that this is, there is some kind of turning and that people are really starting to care more about one another. I think that is true for some portions of our population. I don't think it's universally true. I think that there is a shared sense of pain in paying for healthcare that has started to affect a huge portion of our economy, and that is actually maybe what's driving this and making it more obvious for a lot more people. I think that our businesses are suffering under the weight of healthcare costs. Small businesses don't provide it to anybody. We're starting to see that this is not just taking a toll on people who can't afford health insurance, it's taking a toll on our overall economy as a whole and the ability of us as a nation to function and compete in a global marketplace. That is happening with healthcare too, and I think in some ways that is really driving maybe some sense of unity on this issue.
I see a hand here. Does someone have a microphone? No.
Hi, I was very pleased with Josh's comment regarding scope of practice and all practicing towards the top of the license. And I would echo that not only for those that are licensed, but also for more thoughtful use of non-clinicians, the kind of work that Tom Bodenheimer and others are doing with health coaches. But my question to all of you, to what degree are the various interest groups that have a stake in this embracing that position? And if not, what, if anything, can we as the UCSF community do to influence that?
Well, I'll take a first stab. A couple things that are happening that Andy referred to earlier about courage around delivery system reform are actually happening despite health reform legislation. And thankfully it isn't despite a change, but we're happening ahead of it. And I can give you an example of something that at least brings some of the parties, not all the stakeholders, together. So both in Sacramento and now in San Francisco, there was a large either employer or union that went to its primary insurer and said, you have 1 year to cut your rates, or we are taking all of our insured to your competitor. And it's a competitor that never gives them back, by the way. And this galvanized otherwise completely disparate parties, meaning the hospitals and the doctors and the insurers, all came together in the plate to try to preserve their ability to care for a population. And it has begun to loosen some of those things. They're not all related to scope of practice, but some of them are. So I would say that in a few examples, we've seen a little bit of ability to affect this. I don't know at a legislative level or when you look at sort of professional societies, maybe not so much.
A quick micro question for Andy, and then a more complicated macro one to Jamie and David. Andy, under the current formula, people on the state Medi-Cal program get 50 cents on the dollar from the feds, 50 cents from the state. In 2014, do they get the same payment ratio? Okay,
Yep.
thank you.
So there is a mechanism that traditional people have the same reimbursement from the state, but it's the new category that will be the 100% for the first 3 years and then tapering down. It's recognized that it may be complex for the state to kind of figure out, would this person have qualified under the old rules or will they qualify? And so there's actually a regulation moving through that will give guidance to states about how they may, in fact, be able to sort of blend that all together and kind of decrease some of the administrative complexity. But in theory, what you said is exactly right. The old people get the old rate, the new people will get the new rate.
But in 2014, the old people get the new rate too.
No,
No,
that's
no.
what I'm trying to say. The
Okay.
old people stay at the old rate. And this is actually, okay, let me just actually take a moment. This is critical for understanding some of why the states are a bit frustrated with the federal government. It's been referred to sometimes as the woodwork effect. And so when I referenced earlier that there are people who are eligible but not enrolled, by making an individual mandate, a parent of a low-income child who may not have signed up previously for Medi-Cal, but now because of the mandate does, they're not a new eligible. They're actually someone who's, they are new eligible to you and me of understanding, oh, they're new in the program, but they are qualifying under the old rules of eligibility, and so that the state is only entitled to 50 cents on the dollar.
Okay, that is really complicated. Opposition to the ACA has been a galvanizing theme for the Republican Party, and it is conceivable that it could carry them to the presidency, the Senate, and the Congress, the House. If that happens, you're the prophet, you know, what will be the strategy to unravel this?
Professor.
Well, you kind of predicted the 5-4 ruling, so
Yeah.
what's going to be their strategy in 2013?
Their strategy will be, first, to, as you say, to win the White House. Second, to win the Senate. They do not actually, because it was upheld as a tax provision, they actually will not have to worry about a filibuster. So the ACA was passed actually as a cost measure, and so therefore is filibuster proof, because when they lost Ted Kennedy and they lost Massachusetts, the Republicans could have filibustered it, and so on the theory of what goes around comes around, the Republicans plan to do exactly the same thing. So if they have the House, they have the Senate, and they only need 51 in the Senate, they will try to repeal it. And so far as I know, procedurally, and Andy may have a follow-up on this, procedurally there's not much the Democrats could do about that. And so I think that get out and vote. I think that the actual machinations in the Senate, there may be some procedural obstacles that can be thrown into the way. As Jaime mentioned, and she may want to follow up on, there are a lot of provisions that the Republicans don't want to get rid of. Whatever they say now, they're not going to get rid of it. So even if they were to repeal it, they're going to have to repeal it in piecemeal fashion, and that itself might present procedural ways for the Democrats to step up and make deals on the provisions that they want to keep. It's really the individual mandate that has made people see red. But they lost the first battle. They lost the constitutional battle. Now they want to frame it as a tax issue. It was always a tax issue in terms of being obligated to pay either to buy insurance or to pay the IRS for failure to buy insurance. That always existed, but there will be some effort to take advantage of the rhetoric of raising taxes. Of course, Romney has some difficulty with that because the Massachusetts plan did exactly the same thing. So to the extent that he's accusing Obama of, quote, raising taxes, and it's not clear how this would be raising taxes because you're actually getting a good for what you're doing instead of paying a tax bill, but Romney's in exactly the same position. So he doesn't have clean hands in that regard. So it's going to be a mess, but I think that we ought to do everything we can to ensure that one of the two branches or one of the two houses in Congress remain in Democratic hands.
Yes. No, I think that if they get the House and the Senate and the White House, I think this bill will be gone. And I think it will be, I mean, it is what Romney is running on. It is, you know, if you looked, if you just typed in Mitt Romney, there'll be 10,000 pictures of him and saying repeal, 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 which is so incredibly ironic. But I think that they will do everything. I think they will repeal the whole act and then potentially try and put back the things that they like or as part of maybe a larger bill. Or they might just leave healthcare out there to dangle. I think that there will be some pressure on them to put something back in. It will not be nearly as comprehensive. So yeah, I agree with David. To the extent that you like this bill and you want to keep it and you want to see it stick around, as much education of everybody as you can possibly find about how it is going to benefit them, I think is really critical. A lot of the polling data shows that people they just don't understand it. They don't understand how it applies to them. They don't understand that they're already paying for the uninsured. It's not that we're adding an additional amount. Like very, very intelligent people do not understand that we're already covering care for a lot of individuals and through uncompensated care. And so to the extent that we can get the message out about how this works, and that people aren't going to be paying, thousands and thousands and thousands of dollars that they really can't afford, I think is going to be very important.
H.L. Mencken said about the theory of democracy that the people get what they want and they get it good and hard. So I defer to H.L. Mencken on this.
Well, just for Andy, we actually have quantified the health cost savings associated with tobacco control, and you get a 50-to-1 return on investment, and very quickly. So we've even published it and stuff. So you can give that to the people in Congress.
It actually showed up in the bill.
Huh?
So you may not be aware, but it actually showed up in the law. So that was one of the small areas that the CBO did actually say prevention worked, and as a result, Medicaid programs across the country which did not cover smoking cessation strategies, it is now part of a defined benefit within Medicaid that they have to cover those treatments. And so, in fact, it was I can't remember how many hundreds of millions of dollars were estimated, but that was actually one of the few areas of prevention that came out as a cost saver.
Yeah, well, anyway, but my question, that was my comment. Now, the question I have, to the two lawyers, I mean, you mentioned that, that there can be a kind of rearguard litigation action against the implementing regulations. And I would just like to hear a little more about that. And because it seems that right now you have this situation where now that the Supreme Court has acted, the sort of de facto position is to move forward. And you have the hospitals and the health insurance companies and a lot of state governments. And so at one level, it would seem that there may be a lot of important interests that maybe didn't love the bill, but were continuing to gum up the gears is actually going to cause a lot of trouble for them. But on the other hand, anybody can file a lawsuit, and there are wealthy interests that are going to fight this to the death. So I was just wondering, I mean, how do you see that, playing out? How do you see the courts intervening if someone goes in asking for temporary injunctions and things like that? I mean, since you predicted the outcome so brilliantly, I mean, could you sort of tell us a little about kind of how you think that would happen and how you think the courts would deal with it and how the various interests that are involved would react?
Jamie actually might be the better prophet on this issue. As a constitutional matter, this litigation is dead. There are no constitutional issues left. They were all settled in the ACA case. But after Brown versus Board of Education, it took decades and decades, and even today, you could say that Brown has not been fully implemented. So the court might decide a case, and then there might be vexatious litigation and simply not abiding by the law, and then having to drag them in the court to force them. There's a lot that needs to be done under the Act in terms of regulatory development and public comment, and so there are a lot of choice points where litigation could pop up, where people fail to act because they refuse to act, and you have to bring a cause of action to force their hand. So there are lots of things that, in terms of implementation, because there are so many moving parts to the Act, but they're not constitutional, so I don't need to worry about them. But there is certainly the potential for a great deal of litigation, I think.
Well, one of the areas of litigation that is likely to come up is sort of contraception coverage and who has to provide it and where does it come out and what do they have to cover, and that might actually get into your constitutional realm.
I stand corrected.
But yeah, I think those are the kinds of things that you're likely to see pop up. We don't want to cover, people litigating different parts of the minimum essential benefits plans, people litigating different things that are required for, I don't know, a whole host of things. I think the essential benefits plans are going to be one of the things where we really see litigation on a number of different fronts, and people love to litigate abortion and contraception.
But with that, I mean, people love to litigate.
Right.
But do you think that the fact of the litigation
is good? No, I don't think so. I think that I think what will really cause implementation to go forward full steam is after the election. once we know, there are still a lot of states and still a lot of people who are saying, okay, we lost or we won, however, wherever you are, the Supreme Court battle, and now we're still not going to do anything until we see what happens there. So once that goes forward, I don't think little fights at the state level about how to, how this is going to go forward is going to gum up anything going forward, really, as on the overarching bill as a whole.
And by the way, I do predict that the Democrats keep the Senate.
I feel so much better.
You heard it here first. So we have a question up at the top, and then maybe we can get a microphone here.
Yeah, I have a question about whether anyone is really going to say the emperor has no clothes. And this is because it's pretty well established that a large part of health insurance premiums are the administrative overhead costs. 40 years ago, administrative overhead costs were 5 to 10%. Now they're 40, 45%. As a matter of fact, the insurance industry has a term called medical care loss ratio, which means every dollar they spend on medical care is considered a loss. This is their philosophy. Now, the ACA does have a provision for capping that, but everyone I've talked to says, oh yeah, they'll get around it, they'll do creative financing. Is there any chance that people will say, no, you will not do creative financing, that you will return, to the payers, the healthcare services that you're supposed to provide?
So, you're clearly very knowledgeable about this topic. The medical loss ratio, which is that concept of how much of the dollar is going for the patient versus administrative running of programs, is set at 80% for health plans in the law. I hear what you're saying about are there going to be ways to work around that. One of the things that happened in Massachusetts, which again is sort of the basis of the federal law, was that subsequent state legislation gave enhanced powers to the state insurance commissioner to really have clout in negotiating potential pay increases that or premium increases that were being asked of by the health insurance companies in that state, and in fact there's been pretty significant pushback there. You may be aware that the state health insurance commissioner here, Dave Jones, has also been very actively pushing for California to have that as well, and I believe there's going to be a ballot initiative in the next election that will give Californians the chance to decide if they want to give that level of power to the state health insurance commissioner. So I think it's a really important issue. It's complicated because some of the things that get buried in those administrative costs may in fact offer value. So it could be some things like care management or the capacity to use information technology and electronic health records to monitor populations. So it's not a direct service to an individual patient, but is happening more on a population level. And we just don't have fantastic accounting mechanisms to sort of say, that's a wasted administrative dollar, that's a well-invested one. But I do believe at least ACA has set some standard for the first time of at least saying, hey, we care about this issue. We're not looking for just endless profits coming out of these health plans and going into investors' pockets and so forth. But look, it would have been fantastic to have had additional things like public health plans as a way that might have been able to keep administrative costs lower. I think you're probably familiar, and others are familiar with the fact that the Medicare program, which covers so many people, the elderly in this country, actually keeps its administrative costs extremely low. And for many people, that would have been a fantastic model to have spread from. But if you recall, the debate in Congress just did not allow itself to get 60 votes in the Senate and to have a public insurance plan. And so, unfortunately, we don't have that today.
I actually wanted to just follow up briefly and get to time for a couple more questions and ask Josh, because when we were talking about the politics of repeal, when ACA passed, there were a lot of hospitals and payers who were supporting it, and they see the need, as Jamie mentioned, to relieve the burden of costs on their organizations and their business. I got an email from an IHPS colleague last night saying this is who's in favor of single payer, who does not see this as good news at all, and sort of wished that ACA had gone down, because then there would have been a chance to build it up the right way and address a lot of these issues. So I guess my question, Josh, to see if you want to take a swat at, is from the perspective of providers, what does this look like, and how scary would it be if after the election there was an appeal attempt made? What are the politics there? Because it seems to be going both ways.
Sorry, do you mean if there were a repeal attempt that was successful?
Or even if one was mounted, are the politics going to shift, or are the hospitals and the providers still going to feel like
wow.
we need this?
All right.
If we're going to, I know, not the.
I'm going to take a random hack at that
There we
then,
go.
because my guess is that the hospital industry will remain supportive, because the big picture is more people with insurance has value to the hospitals. Whether the insurance industry will remain supportive, I wouldn't even hazard a guess. But I do think the American Hospital Association will continue to be supportive, even with a repeal attempt.
And to follow up on that, but with providers, I mean, it's awfully hard right now to find physicians who are going to take Medi-Cal. You know, and now this is expanding. How are we going to find people to treat these patients? And the other question that I have is about the costs of this. You know, and I'd be interested, Andy, if you feel the initial reports by the CBO that this would not cost money are still valid. Because as we're trying to educate voters, that's one of the big concerns, that, yeah, this is nice, but it's going to be unbelievably expensive. And on the part of providers, and I'm involved with a lot of professional organizations, you know, a lot of them are saying, well, this isn't going to affect us. We're not going to see these patients anyhow. I mean, we just can't afford to do that with all of the debts that, you know, people get out of residency with, and they're not accepting Medi-Cal. So unless they're forced to do it, which is a whole other level, that's another set of problems. But I wonder if you'd comment on both of those things.
Well, one thing I want to point out that, you know, we are all appropriately very worried about the cost of health care, but it's not an incredibly widespread a bit of information that, in fact, the last few years, we've actually starting to see a fairly dramatic slowing in the growth of health care costs. And it isn't to say that it's at the level that we would ideally want it to be, but there is something starting to change. And you know, maybe it's that when you pass a law like this that people start to in fact saying, well, actually we could have been doing this thing, or and so forth. So there may be something happening, and the pressures that we heard about, the pushback from large employers and unions and so forth, saying, hey, we can't just, you know, keep doing this because we still want to have education systems and other kinds of public services. It can't all become consumed with health care. So I do think that something has started to happen. It's early on, and people are trying to sort of read the tea leaves of what's actually driving that. But there has been a fairly significant slowing of how much the Medicare program and growth of healthcare costs is where it's going right now. Now, in terms of Medi-Cal providers, I think, again, some of this will be very state-specific. I pointed out, I think California currently has the 47th lowest provider payment rate of all of the states, which has a big impact on physicians' willingness to participate. And I've seen recent research to suggest that California has the second lowest rate of physician participation in the Medicaid program of any state Medicaid program around the country. And that's probably a couple of different reasons why that's going on. A big one is clearly the payment rates, which are set by the state. And you may know that the state continues to be in court arguing to, in fact, lower provider payment rates, which I think really could undermine the ability to expand access in the way that we talked about earlier. We do have, as a delivery system, we do have a tremendous safety net structure. We've talked about the public hospitals, the UC systems, the clinics, and so forth. And in some cases, that may give an easy way out, if you will, for everyone to participate in this game. You know, one of the things I love about the individual mandate is that it does sort of level the playing field on the patient side. We don't have an equivalent of that on the provider side of how do we level the playing field to make sure that all providers contribute in some fair share way to what is, you know, is needed. And that would be, I think, a fantastic issue for the profession and providers to take up in some way, which is to say, look, we know some providers will take on disproportionate amounts, but everyone should give something because this is a societal issue that we should all face up to.
I would answer your question slightly differently, Renee, and that is, in the intermediate and long term, preservation of the fundamental system of care being provided in an office visit or in a hospital, if we continue that model, we will fail to reach our goal of cost reduction. So there must be fundamental innovation in the way care is delivered that can't simply just try to preserve the way we're doing it now with a little extra cash.
Maybe we'll do one last quick question, if it's a fast one. And
I'm representing the elderly. Is this going to affect Medicare, and if so, how?
Great question.
I have no idea how it's going to affect Medicare.
Well, I think there are certainly many provisions in the law that address specifically things in Medicare, and some of them are, in fact, Dr. Adler talked about earlier. There's a lot of investment in innovation to try to change the delivery model. There's a lot of investment in changing the payment model for Medicare beneficiaries so that there are more bundled payments and so forth. Something that we didn't talk at all about today, but that you probably read about in the news from time to time is, these automatic cuts that are supposed to kick in for providers, for physicians to get a dramatic decrease in how much they're paid by the Medicare program that the Congress has continued to bail out but has never made a permanent fix to. So there's no question that the Medicare program will be scrutinized and to look for finding more efficiency in the ways that were just referenced that we have to do in general throughout our healthcare system. I think it is recognized that the elderly are, very important group as a voting group, and in terms of a program that is generally rated as the best running, health insurance program around. And so I think there'll be great care taken to try to preserve that while also trying to find some financing efficiency. But, we also read about at the same time our federal deficit and so forth. So there's no question that Medicare is a large component of that will undergo scrutiny. But how the specifics of that play out and how effective we can be at taking out waste while leaving, all the good aspects is, I think, the details ahead of an implementation.
We have 1 minute left. I'd actually like to take this to thank our panel. They had an incredibly difficult task. They got the opinion yesterday at 7 a.m., actually 7:14 a.m. And I know they've been very busy gathering their thoughts. So thank you all very much, and thank you all for your questions and engagement.